platform. You can tap into that platform, and hopefully that will give you the guidance that you're looking for. The second thing is collaboration. That's a big part of what we're looking to achieve. And how are we going to do that? Through education, training pathways. As we've heard already about the trainees here and the difficulties that you're facing, hopefully we may be able to help you with that. Bilateral fellowships. We can learn so much from you and likewise you from us. But we'd also like to support international medical graduates. So those of you who are looking to come to the UK, for example, or those of you who are already in the UK, how can we support you to make the career progression that you're looking to make? Other things, patient-related pathways, research and innovation, how can we use the huge data sets that you've got to help you publish and become known on the world scale? I think something that we feel quite strongly about is that we want to know what you need. We are not here to tell you what to do. We would like to know what the local problems are, what the local needs are, and how we can help to empower you at the local level. We've heard about why we're doing this. I suppose a little bit now about the rest, who, how, and what. As I said, I would introduce you to the non-exec committee. These are the names here. For argument's sake, what I'd rather just say is that actually this is about team. It's not about any individuals in particular. We are very proud of the members that we have and the work that they are already doing. And like I said, this is about us as a team. The second thing to say is, how are we going to achieve this? We have a strategy, we have meetings, and we discuss this quite often. But we are hoping to create clear communication channels. That's, of course, amongst ourselves, but of course with yourselves as well. We're looking to get a website up and running, which inshallah will be ready by the time we speak next, and to have an email account that will be easily accessible for everybody, and if there's any questions, we can help. To gain visibility so that you can see us at meetings, we can see you, and we can help you in any way. But also memorandums of understanding so that we can make this relationship formal where it needs to be. It may not be for everybody. So that we can make courses and do teaching, interview skills, research skills, all of those sorts of things. Local empowerment, like I said, local alignment, that may be through fellowships, that may be through courses. But engaging our members, be it the members in Pakistan or be it the members in the UK. And lastly, to hold ourselves accountable, to have performance targets and to ensure that we meet those targets as well. So it gives me great pleasure to launch Pius at Pius 2024. This is the program going ahead in a few minutes. And like I mentioned, we are hoping to be able to sign memorandums of understanding where people would like to and where it's appropriate. This is just a little snapshot of some of the work that is already being done and some of the people that I'm sure you recognize. It's about working here, but also working with our Pakistani colleagues in the UK, in the US, wherever else they may be. And with that, I'd like to thank you for listening.
Okay, thank you very much. So questions, we have in fact several minutes. So any comments from anybody? Faculty, any comments? And then over to the audience.
I think it's
There's one here.
So let me help
There's
you.
one here.
Thank you very much for introducing the PIUS. I'm aware that there is an international chapter or a UK chapter of Pakistan Association of Urological Surgeons. So is this something which is totally different, or this is just offshoot of Pius?
Okay, I can answer that for you. So several years ago, some of us, myself included, we proposed to Pius that there should be a Pakistan Pius International Chapter. In fact, this story started with Mumtaz Ahmed from Lahore. So how many years ago was that? Any ideas? It's got to be at least 7, 8 years, yeah? And then, it was slow. And I have to say, a number of people were instrumental in actually getting at least informal recognition. There's no constitutional amendment or formal recognition. In fact, I asked for one and I was told it wasn't necessary. So as you know, over the years, we were instrumental. In fact, we founded the Pius EAU session, which is still running, and I was the founding chair of that. And then we were told more recently that Pius International chapter by the executive committee wasn't required. That Pius centrally wanted to handle international affairs, which is absolutely fine. That is their prerogative. So we dissolved the Pius International chapter, which I had registered with an executive body, with the constitution, which was obviously fit for UK purpose. And we decided in UK that we will set up an independent organization called Pakistan International Urology Society, the aims of which are absolutely identical to what we had proposed for Pius International chapter. So that's where we are, okay? And I don't think this is the forum to go into the whys that that's happened. I think what's important is that we need to look forward to going forward. What we want to do, our aim, as you heard from Ron, is very clear. There are a lot of very good, outstanding Pakistani origin urologists throughout the world. So most of them are located in the UK, as you know. Many of them are in Ireland. Then there are many in Middle East, and there's a very handful number also in USA. We have been in touch with each and every one of them. They all are very passionate about giving something back to Pakistan. In fact, they're very emotional and they want to do something more. So we will provide them with an international platform. What I'm hoping is that we will continue with our good collaboration we've had over the years throughout Pakistan to continue this work forward. So I think that's probably the essential background. I hope someone that answers your question. Anybody else?
Mateen, I would say that I think it's a great initiative, and Pakistanis who are working abroad, especially in the UK, and in all the developed world, I think Pakistan is going to benefit from their expertise, and if whatever help they can provide, it will be great training for us as well. So I think we should appreciate this activity and fully support it.
Okay, so in the interest of time, thank you very much. Would you want to introduce the next?
Okay. It's my honor to introduce Asim Masood Chaudhary, who's a consultant urologist in Bedford, in UK. He's been coming to Pakistan, established a charity hospital in Ahmedabad, somewhere there as well. And he comes and teaches. I think he's been doing it regularly, which is really appreciated. And I think the treatment provided at Ahmedabad is excellent. What should it be of charge?
Thank you very much for the kind introduction. Assalamu alaikum wa rahmatullahi wa barakatuh. Jazakallah khair for giving me the opportunity to be here today. It's an absolute pleasure to be talking to colleagues. And today I'm talking about a dream that I had a few years ago. And it's been absolutely an amazing journey over the last 5 years or so to what we've been able to achieve. And inshallah, we will continue to work together and achieve a lot more going forwards. So we start in the name of Allah. This is the hospital where I work. I think many of the colleagues sitting here have been there. And alhamdulillah, it's a good department. And we welcome our residents to come here to Bedford for clinical attachments, and when the opportunity arises, we welcome to contribute in training. Nothing much to disclose. Right, so I'm going to focus today on the work we've done in terms of managing kidney stones. So just a couple of slides to show that kidney stones remain a very important component of urological practice. And you can see here, over the last 100 years, the incidence has been rising. We still don't know why, but it continues to rise as we move forward. We're not going to discuss the reasons for it. And why these stones are very close to my heart is this slide here. You can see the maximum incidence of stone disease happens around the age of 40, which is the peak age in a population that is delivering or working or contributing to the society. So if you improve the quality of care given to the kidney stone patients, you actually have a huge impact on the health of the nation. I think we'll stop there on this subject. A few very simple facts about kidney stones. It is a global disease, it is a global health issue, and affects younger population. It still forms 40 to 70% of the workload in most urological units. And to manage it in an effective way is a global challenge. For example, even in our hospital with best facilities, patients with stents have still to wait 3 months to get their secondary procedure done. So it remains a challenge to manage these patients effectively. Right, I think this is an interesting slide. I'll spend a couple of minutes on this. In terms of thinking finances, that's very important when we are working in our professional life to think about the financial impact of what we do. Now, this slide has been produced by a company which is involved in research and forecasting what is happening in the world. And as you can see, because of the technological advances, minimally invasive techniques coming in, the expense of on managing the or the funds or the funding which is used for treating kidney stones is going to increase threefold over the next 5-6 years. So because of the digital technology coming in, miniaturization of scopes, lasers coming in, and so on and so forth. And what slide is trying to tell you, anyone who invests in stones is going to make money wherever he may be. So it's a very profitable area to focus on for multiple reasons. Technology is going forwards, and as we see, the open surgical techniques there, which have served us for many years, are now not even in the equation as we progress in the 21st century. And it's all about endourology and laparoscopy. Right, I'll recommend everyone who's not seen these guidelines to go through. I think they are very nicely written guidelines which were introduced this year at EUA, and I think they have made the management of stones very scientific, and the most emphasis on tailored management or individualize the care, and also follow-up, which is risk stratified. So the whole area of managing stones and following them up has become much more scientific than before. Right, so we all are aware of these treatment options. We won't again be going into details, but these are the techniques that we are using every other day. Shockwave, lithotripsy, PCNL, ureteroscopy, and RIRS. They are the mainstay of the current treatment today. As you can see, the open surgery is almost out of the equation. Now let's have a look at what's happening in Pakistan. Shockwave lithotripsy was introduced in the 1980s and became popular, but now because of various reasons, lithotripsies have gone out of function. And if you look at today's data, less than 5% of patients in Pakistan are being treated with lithotripsy because of various reasons. Then we had PCNL that was introduced in the 90s, and then ureteroscopy came in, and then flexible ureteroscopies came in the recent decades. But still, what we have is 50% of all stone procedures are still done in the form of ureteral lithotomy or pyelolithotomy. I think we have to congratulate ourselves that we have achieved quite a lot in the recent years by addressing the rest of 50%. But catching up with the other 50% remains a challenge, and we need to continue to work hard. So about 12% of our population is going to have a stone sometime in their life. So if you look at the Pakistan population, it's approximately 231 million. It's rising. And if you look at the total numbers, they are mind-boggling in terms of number of stone patients that we have to deal with. So what we have, the resource that we have to deal with this, we have about 700 to 800 qualified urologists, although most of them do come across stones and deal with it, but they do not have the facilities they need follow the guidelines. And if you look at this, only 4 pediatric urology centers in the country. 70 adult urology units. Out of those, 40 now do have a laser, which is the progress we've made over the recent years. But having said that, another 30 out of those 30, maybe another 10 do have laser, which has become dysfunctional or non-functional over the years. So we need to continue to work, and I think laser should be there in all designated urology units which are dealing with stones. This is what we need to work towards. So there's a huge gap to fill. And this is where we need to work together, collaborate, and make it happen. So I think I just mentioned a few challenges that we have to face up to in addressing this huge problem. We have got problems with finances. We don't have enough funds to pay for the capital investment and the ongoing costs. We do not have enough resources to source trained workforce. We have multiple bureaucratic hurdles. Anybody who works in Pakistan is well aware of these. And there are centers which can afford it, but there is an inherent inertia to resist change. And this we see, unfortunately, quite commonly in some places. Right, now with those challenges are lots of opportunities. We have got large number of patients, which are generally ASA 1 or 2. So they can be operated even in sort of hospitals where intensive cares are not very well equipped. We do have very sort of we have got lots and lots of young trained urologists who are keen to specialize in stones and keen to learn these techniques. And we do already have in existence international and national collaboration. It's to exploit this and make it work for us. There are training centers and trainers both available. So these are the opportunities to develop. Financial assistance is available if we try hard enough in the form of donations, grants, and government support. So this is all very feasible. I'll just give you an example how this dream has come about and what is happening. Now, this is the dream which I had many years ago. I was working in Pakistan in the first half of this century, and that's the time when we started to talk against pyelolithotomy. Many colleagues dislike that, but I still insist that pyelolithotomy is an obsolete operation, should not be done. And the answer to that is this is only possible through providing the service which is available throughout the country. And that was the dream I'm still working toward, that every district has a designated stone center with facilities to do the procedures that we talked about. So setting up designated stone centers is a very cost-effective aim to have and to develop this capability to provide this high-quality treatment. But then this comes the challenge, that it is how do we deal with the cost? I think the answer, I'll just show you what we've done, achieved successfully through teamwork, developing networks, allowing delivery of high quality care at low cost, and moving to the day case work. I am surprised still, even our centers of excellence are so resistant to change, not keeping the patients in the hospital and providing these services as day cases. This is again, we need to cooperate with each other and get this thing in. You don't have to keep these patients in the hospital, other than social reasons, and they are exceptional. So we spend a few words on what we've done in a remote area of the northern part, which is near Havelia is a small town near Ahmedabad, and a model stones treatment center has been established there. It is in the north of Pakistan and drains quite a big area of Mansehra and the north of Gilgit as well. Now this is a tidy little building, and you can see it as you come down from the motorway. And this journey started in 2021. We started an operation room there. It already had a dialysis facility there, and we started the urological services. And so far, in the last sort of 4.5 years, we have performed over 3,500 stone procedures. And these are the two things I take pride in. We've had no mortality, and we had not converted to open surgery for even a single patient. This can happen in Pakistan. This is what we do in the UK. And you can achieve similar results here if you work together. Now, it's, I think, high time we seriously think about this part, that it's time to say goodbye to the open procedures when you're managing stones. And this is something we need to, I think now the message is getting out, and more patients are actually asking for this kind of service. Right, so this is a diagram showing where we have designated stone centers with facilities to provide this, but still, as you can see here, there are huge gaps. So we need to work harder to fill in these gaps and cover the whole country, especially big gap here
2 minutes.
in this area, which we need to focus on. So these challenges that we mentioned earlier, we addressed it in this stone center by international fundraising, getting trained workforce work for us through volunteering and incentivizing, and the whole process runs through a charity. So no one is making money out of this as you proceed. So doing this has led us to provide these facilities as very subsidized rates and free of cost to patients who deserve it. I think we don't need to go through this. This is all standard stonework. Now, the umbrella organization that sort of sees this, that we follow the principles of charity, we've registered Rama Health Foundation, which is looking after all this activity that is going on. And this is our aim to achieve in the next few years, inshallah. Already a lot of work is being done in multiple centers all over the country, and we are making progress. We are providing equipment as well. We also help with the training, and our message remains the same. We are on track, and we need to work together to achieve the same in the near future, inshallah. Finish with that.
Thank you very much. So we have 55 seconds. So quick question, otherwise we can take it at the end.
Awesome. We all appreciate what's been done there, especially being in Ahmedabad for quite some time. There's just one thing that keeps coming to my mind. As part of the management plan, doctors who are working there, do they also consider prevention of recurrence of stone? Is that in the management scheme?
Yeah.
Problems?
I think when we talk management of stones, the prevention is a part of it. Yes, we do have stone prevention leaflets, and they go through metabolic analysis where indicated. So it's all in place.
That's really important because I've seen this in practice at research.
I think prevention is always a very important part.
We'll come back to this later. Hopefully we'll have time at the end. Nasser, you want to introduce the next speaker, please? And before we go any further, for the sake of the Almighty, please, can we keep those doors closed? It is so impolite for the speakers. And Salman, I'm grateful you made your attempts, but we have to change our culture. You want to speak? Leave. Go away. Okay, don't disturb the audience. So please keep those doors closed. So over to you, Nasser.
Next speaker is Dr. Pius Mumtaz.
I want to add
Later.
Professor Pius Mumtaz, who's got interest in robotics and cancer surgery, working in the UK.
Thank you, Nasser, for the kind introduction, and thank you, Pius, for having me here today. My talk is on how we can transform renal cancer surgery by harnessing artificial intelligence for better outcomes for patients and from the surgical perspective as well. The reason why I have taken this, been asked to give this talk, I work at the Royal Free Hospital, which is a specialist kidney cancer center. We see about 500 to 600 patients for surgical procedures, and our surgical workload for robotic partial nephrectomy has significantly increased. There were times when we were doing both laparoscopic and robotic partial nephrectomies. Now, 99% of our partial nephrectomies are done robotically. That's one. Number two, the volume workload has increased. We do about 200 partial nephrectomies a year. And for that reason, the complexity of renal cancer surgery has increased, and the number of complex renal tumors that we see has certainly increased. So we want to see how AI, for a person like myself who's aging, can help to improve the understanding of the complex renal anatomy and hopefully improve patient outcomes. As I said, we are a specialist kidney cancer center. This is just a team here. All people in this photograph are surgeons or nursing staff, fellows, surgical care practitioners, and some management, one or two people. They're all working towards giving care for and managing renal cancer patients. So why we need to have AI in renal cancer surgery? It is happening in other surgical fields as well. We know the renal vascular anatomy is highly variable. We have complexity of renal tumors with high nephrometric scoring. We have renal fusion anomalies, variable calicial anatomy, and of course patients with significant comorbidities. And as such, we need to harness some aspects of AI to improve the surgical outcomes so that we can offer nephron-sparing surgery with minimal positive margins. And of course, surgical experience is highly variable within the unit. So any help to younger surgeon trainees is welcome. So what is the role of AI in renal cancer surgery? It's really to enhance the preoperative visualization of the normal 2D CT images that we see so that we can better understand the complex surgical anatomy, and so we can make better preoperative surgical decision and hopefully use these 3D imaging for intraoperative guidance, and then in the future to develop autonomous renal cancer surgery and help train and predict outcomes. So currently we have this 2D CT scans that we see preoperatively. We look at the arterial phase, venous phase, pituitary phase, and mentally reconstruct to see the relationship of the tumor to the vascular anatomy and to the calicial system and the location of the tumor and how we plan. So we've developed an AI segmentation algorithm where we use convoluted neural networks to segment the 2D scans into 3D images, and this can be done using AI guidance. And we develop this image here, which is a 3D, and I will run this very short video. What it looks like, the green part is the large renal tumor. You can then take the tumor out, understand the depth of the tumor, the course of the renal artery, the renal veins, and then you can make the kidney tumor, the renal bed transparent, and you can see the depth of the tumor. So you really understand the location, depth, size of the tumor, the calicial anatomy, the course of the renal arteries, and how you can plan a partial nephrectomy, and more importantly, understand the base of the tumor and how you plan your renorrhaphy. And this is another example. We are moving to a nuclear resection, which is an evolving technique. And with this 3D image, we can then understand the bed of the renal tumor and excise the tumor with much more better confidence, understand the depth, and then go on to identify the calicial system. So these are done much better preoperatively. You can use within the robotic console and place these 3D images within the console itself, and then go on to proceed with help of a robotic ultrasound and carry out a robotic partial nephrectomy with much more certainty and safety. We've developed similar 3D models for horseshoe kidneys. As you can see here, this is a complex renal vascular anatomy. The tumor is in the posteriorly located, very much abutting to the calicial system, and you can understand this preoperatively, plan where your vascular anatomy is, and then go on to resect this tumor. We've gone on to do several cases and published these in the Journal of Urology, both fusion anomalies and ectopic kidneys, and carried out both open and robotic partial nephrectomies successfully. Here's a case that we recently saw in a single kidney, very endophytic renal tumor. We carried out a bench surgery, took it out, and carried out the partial nephrectomy, and then moved on to save the single kidney. The 3D models are in evolution. We have now developed these perfusion models where you can understand where the kidney tumor is and recognize which vessels are feeding it, and then go on to do selective clamping in solitary kidneys of patients with poor renal function. And the data does show that it does lead to lower clamping strategy and better improvement in renal function profile. These 3D models have also been shown that they provide much more accurate nephrometric scoring, and they correlate in predicting the overall accuracy of the complexity of the case and predict any major complications associated with it. They've been shown to reduce consult time and the hospital stay, and benefit to the patients by improving the renal function, and the hospital stay can be significantly reduced overall. Ability to selectively clamp, reduce cholesterol disruption, better enucleation rates, reduce risk of complications have also been shown. We have now developed a model to see whether we can carry out a successful partial nephrectomy and using these algorithms, and that is currently being evaluated and has been published in a few series. We are running one of the largest multi-centric clinical trial in the UK, which is randomized into 2D and 3D to see whether there's clinical evidence to show that these 3D models are cost effective. We meant to recruit about 350 patients. We are on the road to recruit already 270 patients, and hopefully we'll have some data for one of the largest randomized studies in the UK and certainly in Europe to tell us whether these 3D models will help us improve the surgical outcomes, reduce complications, and reduce the conversion rates to radical nephrectomy. The next step of these 3D models is to use these models intraoperatively. Can we overlay these 3D models in real time? That work is being in progress, and currently people are using manual real-time overlay, so you can overlay these 3D images and help guide, but these are manually registered, still limitations here. And this is a video that I've taken from Wikipedia, which I have taken the consent from, and so they have overlaid these images onto the robotic console and carried out a robotic partial nephrectomy. Of course, there are limitations. You need a second operator to overlay the images on the robotic console and guide it. So time-consuming can be a distraction to people who are experienced. This is our own work at the Royal Free, where my team is working to overlay these images manually again and guide, but the work is still in progress. There are AI algorithms now available looking at Ignite software, which are a bit expensive. You can use ICG to automatically overlay the 3D images and help guide the resection. And the meta-analysis does show that it does reduce the operating time, it does reduce the warm ischemia time, it is estimated blood loss. So there are benefits, but these are early stages and it currently still in research in progress. Again, robotics is progressing. There are several robots that are coming through. The question is now, can we make AI-capable surgical robots? And currently, what we have is that is a master-slave technique. The surgeon operates on the robot. There's currently no, the robot cannot carry out the procedure autonomically, and so we are developing certain AI-guided automation in several aspects of robotic surgery, like can the camera control be carried out by the robot by itself? Can we visually segment the tissues? Instrument segmentation, when we're operating on the kidney, there's a lot of deformation during surgery in real time. Can we overcome that? Instrument trajectory is another issue, and currently we're developing that and understanding different surgical phases of the procedure itself. This is carrying out real intraoperative real-time segmentation that can help guide the surgical procedure. Deformation is being looked at, trajectory planning, because of limitation of time, I'll just move on to that. And then the surgical phase detection, what it does, it tells you which part of the surgical procedure you are. It helps you in terms of training, identify one phase to another, what time is taken, and you can go back and reflect on how you can improve. The next area that we're looking at is predicting outcomes using computer vision, and that work is still in progress. You can guide, use the 3D images, overlay them into the robotic console, and guide the surgical procedure, and that helps to understand the surgical scene and helps to identify the trainee which part of the surgical procedure he or she is working. Looking at the kinematic data, this is matrix data that can predict who is the surgeon operating. As you can see on the left, there's very little movement, and on the right, the instruments are moving quite in a much broader view range, suggesting that there's still a lot of learning to do. You can get the feedback looking at different phases using deep learning networks. That work is still in progress. I'll skip this again because of the lack of time.
2 minutes, thanks.
And so the future is here, how we can integrate robotics with AI. Some steps can be automated with time. Can it lead to global transformation? That's the key thing. Can we uniformly apply these training skills and rapidly disseminate in terms of tele-mentoring and telesurgery? And so there's a lot of work that needs to be done in this third phase of AI aspect of delivering surgical care. So the smarter surgeon is there to come, that will use in the years to come, how he or she will use AI for their benefit. The question is, for you to use the AI, it does not mean that you will be losing your job. If you don't use it, you're more likely to lose it because others who are using it will be able to provide a better surgical outcome. So it is here to stay. And of course, there's a lot of regulatory certifications that are needed. Clinical validation is needed. So currently it's not yet integrated, but I think the future looks bright. Thank you.
Thank you very much. So we have a couple of minutes for questions. Can somebody close the doors at the back, please? Can you close the doors at the back, both sides?